second speaker is Judd Walson, MD. He's master's in public health as well, so doctor and a master's in public health. And he's an assistant professor here at, of medicine and infectious disease and global health and pediatrics, adjunct assistant professor in epidemiology in the School of Public Health. So his research is focusing on investigating the impact or treating and preventing endemic co-infections. So that'd be like tuberculosis, malaria. Helminthes are like worms. It's just like, if you use that word, that's a $15 word, but if you say worms, people actually know what you're saying. So people with HIV have a tendency to get other infections, and these are some of the infections that they can get. And the areas where this is most notable or most rampant, unfortunately, is in Africa, and he does work with the Kenyan Medical Research Institute, KEMRI, in Kenya. This must be a picture from where? Nepal. It didn't look like Kenya. I was just saying, I'm thinking to myself, not Kenya. Okay, so Dr. Walson is a principal investigator. We call that PI for short. He's a PI of a large center grant assessing the epidemiology of non-typhoidal salmonella. So salmonella, I know about this, I'm a GI doctor, it's like diarrhea. He is a faculty co-lead on the Global Health Strategic Analysis and Research Training Program, START, a collaborative program between the Bill and Melinda Gates Foundation, which is just extraordinary and wow, and the UW Department of Global Health. I mean, these guys are taking global health by the scruff of the neck and shaking it. These are the people that are going to make a difference. And global health is pertinent to everybody in this room because tuberculosis becomes untreatable, becomes a disease that we need to be thinking about here at home. All right, just wanted to scare you a little bit. All right, now this looks like Kenya. Okay, just moving along in the various parts of the globe. All right, Judd earned a BA from Pitzer College in Claremont, California, and his MD and PhD from Tufts in Boston. He spent a significant time living and working in Thailand and Nepal, where he worked in infectious diseases, no surprise there, and focused on malaria, tuberculosis treatment, and prevention. So this is all very hot stuff, and so it'll be very interesting to hear what he has to say.
As we think about what we're doing, training physicians, training physician's assistants, training nurses, training other healthcare providers, what is the point? You know, what are we doing? And I think as we think about particularly medical school, you all are here enrolled in our mini medical school. What does it mean to train a doctor? What are our doctors going to do? Are they going to simply go forward and practice medicine? Of course, we hope they will. But they are also going to be the next leaders and the next generation of true professionals. And professionals in that word, I think, encompasses more than just the practice of medicine, but also these young people who you heard from, and as you can see, they're incredibly articulate, incredibly thoughtful. They represent the next generation of leaders in our world. They're the ones who are going to fix the broken health system that we have. They're the ones who are going to help us move forward. And so when we think about from high school moving forward, we not only want to think about what the process is to get there, but why are we going to get there? And I think I'm going to share a little bit about my path to getting here, and I think it's sort of informative. So I grew up in a middle-class Jewish household. I was in Ohio for high school, and I remember one time in high school, I think I was a junior or a senior in high school, I had actually no desire to go to college whatsoever. I was a magician. I used to love doing magic tricks. And I was sitting on the porch with my Bubba, my grandmother, and my Bubba was older, and she was quite hard of hearing. And she turned to me sort of out of the blue from her rocking chair, and she said, "Judd, what are you going to be when you grow up?" And I looked at her, and I said straight away exactly what I was going to be. I said, "I'm going to be a magician." And she sort of just had this blank stare, didn't say anything for about 5 minutes, and then she said, "A physician. Wonderful." And I think, you know, in the end, she was right, but it certainly wasn't the way I was going. And my path to medical school is an interesting one because it's not your traditional path. And I think what I got from that, speaking directly to our colleague here from high school, is that taking the time to figure out not where I was going, but why I was going, and what I was wanting to be, and how the path that I was going to choose was going to be able to make a difference in the world has been a critical, critical process for me. And I feel honored to have the job I have now, but I would never have been able to be here as a senior in high school. I wasn't ready. I wasn't there yet. And it took me a little longer than most, and I will share a little bit of that with you. But I'm here now, and I think understanding that for some of us, it's when you're a sophomore in high school. Shoot, I had friends who knew they wanted to be a neurologist like in kindergarten, and that's what they're doing. But for many of us, it doesn't come that quick, and that's okay. And finding your path is part of the process. And when you find your path, then I think you will grasp it. So I am driven particularly by trying to make a difference in a global setting, in areas of the world where resources are quite scarce and where we really face enormous challenges. And the United Nations has put forth a series of goals to try to focus global efforts, not just in health, but in development. And I'm not going to read them to you, but I think what's striking about these is that many of them do involve health, but also that many of them overlap. I think you can all agree that we can't achieve universal primary education unless women are part of that process. And that we cannot achieve a reduction in child mortality unless we enable women to access health. And so there are many, many things here that we need to do, but the good thing is that they're intertwined and that we can meet measurable targets. And we, in fact, are making dramatic progress towards some of these goals. So as I said, I didn't quite go a direct route. I was a juggler and a magician, and I actually didn't want to go to college, but was convinced against my will to do so. And after my first semester of college, I dropped out promptly, and I went off and joined the circus, and I street performed around Europe for almost a year. That's me on the top right. I used to do a straitjacket escape. That's me in Cologne, Germany. I have the audience member in the jacket, and then he puts me in, and I have to escape in 90 seconds. And anyway, I did this for quite some time, and I had no idea what I wanted to do with my life. In fact, I still don't really know what I want to do with my life. But at that time, I really didn't know what I wanted to do. And I learned one really important thing that year, and that was I didn't want to be a street performer. It was a wonderful experience. I toured all over Europe. I had a great time, but it was tiring, and I was living on the street, and it was really hard. And I realized, actually, that wasn't my career goal. But I'm not sure anyone could have told me that. I think I had to learn it, and I did. And I went back to college, and I got completely engrossed in cultural anthropology. And I became a cultural anthropology major. I studied the cultural anthropology of the Himalayas. Believe it or not, that was a possibility. And finding that when I graduated that both jobs in the world for cultural anthropologists at the Himalayas had been taken, I needed to figure out what I was going to do. So I spoke with my cultural anthropology professor, and I told him maybe I'll do a PhD in anthropology. And he sort of said, well, there's maybe 3 more jobs if you do that. But if you want to do that, I suggest you go and live overseas and have an experience and see if this is really what you want to do, just like you did with your street performing. At the time, I had no language skills, and speaking to the person who asked the question, I learned that there's a word for people who speak 3 languages, and that's trilingual. There's a word for people who speak 2 languages, and that's bilingual. And there's a word for people who speak 1 language, and that's American. And and so I didn't speak other languages, and I really wasn't sure what I was going to do. So anyway, he convinced me that if I were to go overseas, it could be a great experience. He set up an opportunity with a research group he had been with to go to Nepal and live for 6 months to study why the Sherpas in far outlying villages in the Himalayas had trouble accessing healthcare, particularly around drug-resistant tuberculosis. They had high rates of drug-resistant TB. They weren't coming in for care. It wasn't clear what was going on. And so I went, and my 6 months rapidly turned into almost 3 years. I do speak fluent Nepali now. And I lived in really way up in the Himalayas and traveled around and tried to figure out what were some of the cultural barriers that were preventing people. And through that process, I started to think about what I was going to do with my life. And I'm probably one of the few people who can actually remember the exact moment I decided I wanted to go to medical school. And it was standing in a forest of rhododendron trees. And I was with the guy who's in the white, with the white baseball cap, who was about 34, Ang Prabha Sherpa, who was a good friend of mine there, who died about 2 years after this picture was taken of drug-resistant tuberculosis. And he was really sick, and I just remember vividly standing there in this forest of beautiful red rhododendrons, watching him coughing and saying, you know what, I think my calling is medicine. I think that's what I want to do. And that's really how I got here. And I think that process of figuring out not just the pathway that I needed to go to medicine, but having a real reason for wanting to do it and being driven really allowed me to be engaged. And so my passion really has been, as I said before, understanding healthcare disparities in the context of the global health. And so this is an interesting chart that just shows on the y-axis children surviving up to 5 years of age per 1,000 live births, and on the bottom, the gross domestic product. And I think what's striking about this graph, you don't have to be able to read all the different countries, is how linear this is. The more money you have in your country, the less poverty you have, the better off you are. But it's also interesting to note that the US isn't at the top of that graph, and we have tremendous disparity even within our own country and tremendous problems with our healthcare system. So let's talk about what this means in terms of training, which is what we're really here to talk about today. You all are here enrolled in mini med school, and we're talking about how do we train the next generation. So first thing to recognize is that when we talk about people coming out of medical school and how many of them are interested in some way in global health, those numbers are staggering, and they're growing every year from 32% in 2000, now almost 60% in 10 years later. And so part of this is if we want to engage this incredible group of talented students and get the best and brightest like you saw today, we need to keep up with what they're demanding. We need to be a competitive place, and we need to be able to get them here. But we also need to have experiences that are meaningful and not just paying lip service to the global health interest. And I think that's what I want to share with you is one of these programs which I think really focuses on creating a sustainable and ethically sound experience for our trainees. Again, just looking at this, if you look at the percentage of applicants who looked at our pediatric residency program who said that the reason that they were interested, or one of the major reasons, was global health, it's also increasing. So this is really important, not just in terms of the opportunity we give them, but meeting the needs that they're coming to us with. Students also have been shown just globally. Students who participate in global health field experience are more likely to end up caring for poor and ethnic minorities either here or abroad. They're more likely to pursue primary care medicine, and they are more likely to express increased interest in volunteering, humanitarian issues, public health, all the things that I hope we can all agree we want our global leaders, our citizenry, to ascribe to. And so this is not just about making more mini-me's to go off and work in Kenya or Uganda or whatever. This is about how do we create a generation of leaders coming out of the University of Washington who are going to fundamentally recreate our world in a more positive way. So as we're working overseas, we're also trying to think about building sustainable change, right? This isn't about giving a medical student a medical tourism opportunity to go over and see sick people starving to death in Uganda. This is about coming together in collaborative partnerships that's mutually beneficial, creating job creators, not job seekers, right? And one thing that you may not all know about, but it's really been almost 100 years until recently that the medical profession itself has looked at how it trains medical professionals. One would think it would happen more often, but it hadn't. And recently, in fact, I think it's 2 years ago, The Lancet published a document that really looked at what are we doing in medical education and are we getting the things we need. And what are some of the things that they found that we really need to reform in our medical education system, I think are pretty intuitive for any of us who've gone to the doctor, right? We need to make sure that the things we're teaching our doctors to do meet the needs of the populations we're serving, right? And that's not actually always the case. We are awful at teaching teamwork as a general rule. I think the University of Washington is an incredible exception. I think that's a huge focus here. We still have persistent gender problems within our profession. We have fairly narrow technical focus. We focus on single encounters that occur episodically instead of figuring out a package of care that goes over a continuum. We focus on hospitals where actually the minority of people are receiving their care. We have huge problems with the labor market, which is now, I think all of you are aware of, coming to bear in terms of the political realities. And we have to focus on how we strengthen our health systems. And this is, I think, a nice call to action that came out of that. I won't read it to you. You guys can all read it. But we really need to focus on how do we improve medical education. And as part of this, we have to recognize that we are members of both locally responsive but also globally connected teams. So community-based experiences benefit the participants, right? So now we're talking about how do we make this mutually beneficial. So we can tell that there are some benefits to our medical students to engage in these opportunities, right? We can understand, I mean, you can't teach somebody here about worms. You know, they're just not going to see it. You got to go to Kenya where there's two types of people, those that know they have worms and those that don't, right? So, and then we can improve physical examination skills. I mean, now you go into the emergency room with stomach pain, and basically Dr. walks in and says, get a CT scan, and we'll see what it is. Well, you can't do that in Kenya. You got to actually learn how to diagnose a patient using your physical examination skills. You also get deeper appreciation of all the issues we've talked about today, as well as some important issues around professionalism and collaboration, which can be hard to teach. And we can maintain this and foster this incredible issue that I think has come to the forefront in the state of Washington around humanism, altruism, compassion for vulnerable populations. But we have to make sure that these things don't happen at the expense of being self-serving. There is a lot of work required to make sure that these don't become a one-sided experience for our students without being mutually beneficial for the populations that they're serving. If you imagine if I go to a new country as a medical student and I don't speak the language and I show up in a rural hospital that's already completely overwhelmed, there's 350 people literally waiting at the line for immunization clinic that morning, and there's a nurse and a doctor to see all 350, and I'm a medical student, I've never seen anything like this, and I step in and the first thing the doctor says to the nurse is, can you go with the medical student and serve as their translator? Now we've gone from 2 providers in that clinic to 1 1/10, right? Because this medical student doesn't know the systems. I mean, it's not about their knowledge. It's about they don't know how to take the notes. They don't know the system of the pharmacy. They don't know how to function there. And we've removed a healthcare provider to help them. So we really have to be careful about the burdens that we're imposing. And we also need to make sure that the care that we're providing is meeting current standards of care. It is not okay for a University of Washington medical student to be doing unsupervised cesarean sections in Uganda because they need cesarean sections. You laugh, but this has happened, not with University of Washington, but with others. So there are also a number of challenges in terms of creating these programs that we have to acknowledge are real. The first is that we really have a requirement and an obligation to ensure the safety and the well-being of our residents. That is the most important, and students. This is the most important thing, that we have to ensure the safety and well-being of our trainees. The second most important thing is we have to ensure the safety and the well-being of our trainees. I mean, this really can't be overstated, and it really is something that you have to take into account. And for example, we have a program running in Kenya, which I'm going to share with you about very quickly. And you know, there are elections coming up. The last elections didn't go so well. I happened to be there, and there was a lot of violence. And so we've elected to not have residents or students there during the post-election period. We have to be cognizant of these things. We have to make sure that we are focusing on building competencies, that we have adequate supervision, and that we are promoting ethical and responsible engagement of colleagues. And obviously the university is worried about legal issues, and that has to be really acknowledged, okay? And then obviously these things cost something. You have to get people to Africa or whatever you're going to do. And partnerships are really critical in doing this. So the way that we can ensure safety, the way that we can mitigate legal risk, the way that we can do all these things is with really strong partnerships. So the program that we've started in Kenya is built on a 30-year relationship with the University of Nairobi and the Kenya Medical Research Institute that started long before I got here. And it's built on mutual trust and understanding between collaborators in Kenya and here, and it's really focusing on partnership. And I think that's what's so important. We have shared mission and goals, we have mutual trust, and when we evaluate it, we look to see if there's mutual benefit in terms of outcomes for everyone. So let me just tell you a little bit about this project, which is a partnership between the University of Washington, the University of Nairobi, Kisii Level 5 Hospital, which is a provincial level hospital in Western Kenya, and the Kenya Medical Research Institute. Really guided by, again, this idea of being mutually beneficial for all of those partners involved. With a shared vision, it's a global child health program designed to equip both United States and Kenyan pediatric residents with relevant knowledge and experience to reduce health disparities among children in resource-limited settings. So again, both the residents from the US and Kenyans are paired together in pairs, one resident from Kenya, one resident from the US, and they work together in a community in Western Kenya. We try to prepare, you saw this earlier, I mean, this is very similar to what you saw with the Global Health Pathway. We're trying to prepare them with careers as advocates for underserved populations, not necessarily globally. We're focusing on all these influences, just as you heard earlier. We're trying to attract the best and brightest, like you saw. I mean, you can't get better than that. And we're catalyzing interaction between residents and community. And this is another really big focus. We're not focused on facility. We're not focused on the hospital. We're focused about the fact is that children dying in Africa, most of them are dying long before they ever make it to a health facility. And so we really need to focus on what we can do with communities to improve the health of children. And we have to provide a structure. They want some sort of a structure to be able to maintain this passion in a very busy and conflicted, time-conflicted environment of medical school and residency. So we pair these residents together for 8 weeks in Western Kenya. They live together, they work together, they do everything together. And they get to see this health system in Africa through each other's eyes. And it's amazing. Obviously, the US residents get to see what the health system looks like through the eyes of a Kenyan. But equally important, a lot of Kenyan medical residents come from privileged backgrounds. Many of them haven't spent time in communities in rural villages. And even if they have, how many of us can imagine what it would be like to look at our own health system through the eyes of another and really start to get some insights, not into that health system alone, but also into our own health system's strengths and weaknesses. It's really powerful. And we focus on the health needs of the community, not on hospitalized patients. And the pairing of residents works great because you don't need to worry about pulling the nurse aside to translate. You've got one, that's somebody who speaks language right there. But our residents also have skills that they can give. They often have stronger public health skills, stronger presentation skills in terms of developing tools for teaching and presentation. Whereas the Kenyan residents often have better clinical exam skills. They have better knowledge of the diseases there. It's a really nice complementary mix. And they focus on the community. They start in the facility at the hospital. They identify children, particularly with malnutrition, and go back to the community to understand the issues that are going on. They do educational activities with the communities and for the communities, using community health workers as partners to look at malnutrition, screening for malnutrition, building diverse kitchen gardens to be able to address malnutrition, implementing different activities around community child health, and effective advocacy, meeting with leaders both at the political level and other non-governmental organizations, et cetera. We've had an amazing project working with traditional healers to help them feel empowered to screen children for malnutrition and help them understand when they can refer into the hospital. So this is a child, 6-year-old child, believe it or not, with severe malnutrition in Kenya. We found out that, in fact, the Kenyan hospital that we're working in didn't even identify malnourished children as a priority for them because they live in one of the most agriculturally rich areas of Kenya. Yet when we looked at our residents in collaboration with the pediatric residents in Nairobi, found that, in fact, the death rates due to malnutrition were some of the highest in the hospital, which goes along with data for Africa. Huge problems with stunting and wasting. And just to point out that all of the diseases that you hear about that cause death in these parts of the world have malnutrition as a major underlying contributor. In fact, over half of all deaths of children probably have malnutrition as some contributing factor. Yet when you look at this area of Kenya, you'll see that it's very agriculturally rich. This is what it looks like. And so what our residents have been able to do is really to start to focus at the community level of why in an area with so much agricultural productivity is there so much malnutrition. And we've now had 14 resident pairs working over the last 5 years to develop a whole host of integrated solutions involving the community, involving other partners like UNICEF and others, and really making a difference in this community. And I'm really glad to say that we've achieved goals both for the hospital in terms of reducing mortality, for University of Nairobi in ensuring a child health community experience for their residents, the obvious for ours. And so everybody's benefiting from that. And I was in Nairobi 2 weeks ago, meeting with all the partners for our 5-year annual meeting, and it's really, I think, a testament to how these experiences can benefit all of us, and more broadly, the global health community. So with that, I'm going to stop, but I just want to thank all of you for being here, and I want to again remind you that we all have a responsibility as citizens here in the state of Washington to ensure that we're training not just the next doctors, but the next global leaders, and I think these students are a testament to how we're doing that. So thank you all very much.